Hey guys, this is Nurse Howie, and I wanted to talk to you about the resurgence of COVID. Hi guys, it's Nurse Howie, and I wanted to give you an update about the COVID resurgence. So as you've probably already known, based on some people's posts and as well as mine, that the COVID resurgence has come back. Now this hasn't been a surprise for us. In fact, we were hoping that it wouldn't happen, but we also realistically knew that it might happen again, and of course it did. So a little bit of a perspective. Of course, I'm only talking about my own hospital, but before we had a 3-pod ICU. Within each pod, we had about 6 to 10 people or patients. Before the COVID, it was all just regular ICU patients. And then during the COVID crisis, 2 out of the 3 pods became ICU just for COVID patients. So we had to seal that off, and that's where I had to work and not only have my mask on, but also have my entire gown and all my PPE gear to make sure that I can take care of these COVID patients along with the rest of the team. So now, after about 3 weeks to about a month ago, we started to diminish the amount of COVID patients, and we started to send them out. That either means that they were either more stable or they were not. So at that time, around 2 to 3 weeks ago, I didn't need to be in the COVID unit ICU as much. It was just mostly 1 out of the 3 ICU pods that were just specifically for COVID patients that were so bad that they needed mechanical respiratory ventilation. Well, a week ago to about a week and a half ago, that census came back up. Now, we're not quite exactly to where we were at the COVID crisis, where it was 2 out of the 3 pods for ICU COVID patients, but we're certainly at 1.5. And so we had to do a little bit of some architectural changes, and we made the second ICU COVID pod, one half of it was completely for COVID patients that are part of the ICU, and the other 1.5 are just for regular ICU patients. So we had engineering come in and bring in a divider to make sure that that each pod was separated from each other. I just want you to know, and I'm going to tell you a couple of things, that there's still some treatments that we're working on for COVID patients. Perhaps in another video I can talk about how these drugs manifest themselves into being put into the treatment plan for COVID ICU patients. It's quite complicated. Some of these drugs are just widely available already, and they're already approved by the FDA, and so they become COVID ICU drugs. So 2 of these in particular, hydroxychloroquinone, which is a pretty long word, and it's also known as Plaquenil. It was usually just used as a medication for people with lupus, and it's also an anti-malarial medication. It was already available for these patients, and so it was easy to just use it off-label into the COVID ICU patients once they found that maybe like a couple of COVID ICU patients, maybe perhaps in China, had reacted to it in a more favorable way. So we decided to use it on our own patients, and of course it got into political hands and it went completely haywire. You know, like I talked about how it wasn't effective on our patients, and it wasn't, if I can find out where it is, but you can probably just Google it. But about a month ago from here, the FDA has found that Plaquenil, the hydroxychloroquinone, is actually quite ineffective. And not only was it ineffective, it was causing people to get worse at times, and it didn't do any better as far as our patient outcomes. Basically meaning the amount of patients that are able to get out of treatment, able to get out of the ICU in one piece, and healthy and without as much residual effects from not only battling a life-threatening disease, but also battling being in the ICU, undergoing a lot of extreme treatments that we have to give them. So the other one was azithromycin, which is an antibiotic that has a modicum amount of effectiveness for people with viruses. As you know, viruses are very difficult to treat because they're not exactly living things. And so when we think about treating somebody who's sick, we usually think about antibiotics right away, but antibiotics has bio in it. For us to have it work, it has to have it has to be a living thing. So usually bacteria or any other microbiome, but viruses aren't necessarily bacteria. So antibiotics such as azithromycin has only a little bit of an effect on it, but we'll take what we can get. So now what does that leave us? Basically, we don't have Plaquenil anymore. The FDA has canceled that. What do we have next? So besides the azithromycin that I normally hang up, I also have remdesivir. Remdesivir is an antiviral medication specifically just for viruses, and it works some of the time, but as you know, viruses are very tricky. They mutate quickly and they act fast. And in addition to that, an extra layer of COVID is that we're not only trying to battle the virus itself, but the damage that the virus does to the body. And part of that damage that the virus does to the body is making the lungs and making the patient's own immune system overreact. And when it overreacts, as many asthma sufferers know, it becomes very difficult to treat because we can't just cancel out the body's immune system. If it overreacts, then you have to have a certain specific balance of making sure that it works to calm the body's immune system down, but also not to damage the patient's own body and own cells. So for those of you who have to deal with a lot of autoimmune deficiencies and diseases, you'll understand. The next thing we have is dexamethasone. Dexamethasone is a sort of a steroid, a corticosteroid that the body produces, but we've made a synthetic version of it. But this is also a complicated drug because even though it lowers down these immune systems when it's overreacting to the COVID, but it also has a complex physiological mechanism that makes the body very sensitive. For example, one of these things is that it increases somebody's blood sugar quite high, and so it can be damaging if it's used for too long. So the tricky thing about that is that back when COVID first started to come out, a lot of Chinese scientists immediately published their findings. And before, when we had a lot of asthma patients that were having acute respiratory distress syndrome, which is one of the worst respiratory diseases that you get, corticosteroids was one of the first things that they tried, Solumedrol for one, Decadron, stuff like that. So they found that it didn't really help. In fact, it made things worse in that the patient's outcome, whether or not they survived the virus, was not changed. So they discouraged us from using it at first. So dexamethasone is still a corticosteroid, but it's slightly different. So we're trying that out only because it's available. Now, for us to test whether something is really truly effective, if a drug is effective, we have to have tested it on thousands of people. And as you know, you can probably figure out that we can't do that right now because we're currently battling the COVID virus now. So we can't jump to conclusions and say, yes, this works definitely. It's just that we give it because, one, it's freely available. Two, the FDA has already passed it to be used for something else that's similar to a COVID symptom. And three, because it's cheap. So that's why we use drugs that we use now. It doesn't necessarily guarantee that the patient is going to overcome the drug. And with my experience with COVID patients, not only trying to eradicate the virus, but we're also trying to get the patient to survive. I've had quite a few deaths where the patient had been free of COVID virus and they were already considered COVID negative multiple times over. They were even out of the COVID unit, but when I went to go follow them and take care of them the next week, their bodies couldn't handle it. So, let's fact check the fear though. We're not completely inundated, at least not in my hospital. In certain areas of the country, of course, where it's poor, the poverty level is lower, and there's less treatment available and less experts. Yes, they're suffering terribly. So let's please keep that in mind. But also, not only to give compassion to them, but also to the people who just don't have as much faith as you. When they don't see the virus up close like you and I do, they feel like it's not real, and they feel like we're imposing on their freedom. So try to check cancel culture and try to see if you can try to get them to come around, but straight up arguing with them face to face, head to head, probably won't get you anywhere. A couple more things I want to talk about is calls. I know people ask me about advice for COVID, and I'm more than happy to give it. Of course, it's going to be entirely free, but I do want you to consider that I'm not allowed and I'm not going to give out any prescriptions, complete medical advice. All I can do is just guide you to what you should and can do. That involves me pointing you to resources that are near you and helping you determine whether or not immediate care should be delivered. But for the most part, if you have a fever of at least 101, you're older than 65, you have at least an underlying condition that's not related to COVID but could make it harder to get over COVID, then yes, go ahead and go to the emergency room, get tested. They, at least in many larger cities, they now have universal testing in the emergency room, and they've designed the emergency room to facilitate just COVID suspects versus regular COVID patients. So hopefully you won't get infected trying to come in for treatment. And you can get the results usually within a week. We have a couple of different tests. They're rapid tests, which just involves swabbing the throat, versus true COVID tests, which involves coming in, of course, as you've seen on videos, where we have Q-tips all the way down at the back of your throat. It's not comfortable, but it's the best way for us to figure out whether or not, through polymerase chain reaction laboratory testing, whether or not you have it. Eating out, I know that restaurants are out, and you've probably seen videos of me eating out, because I love eating out at restaurants, guys. I love being outside. But I also love my coffee shops and I love my restaurants. But try to practice a little bit of common sense. Don't try to inundate yourself with statistics over which is more healthier. Washing your hands, or wearing one mask versus two masks, or wearing no masks at all and just practicing social distance. I always try to err on the more cautious side. This is one way where you don't have to worry about statistics, because it depends on your aversion to risk. There's always going to be some risk. Whether or not you want to leave the house, stay in the house indefinitely, you should at least try to be a little bit more cautious. For example, wearing your mask more often than not when you're in doubt, or whether or not you want to really visit your family of like 20 people and really celebrate either a birthday, a special occasion, or a funeral. You do want to be a bit more risk averse, but I don't want you to go crazy. Just be a little bit more conscious about, should I really be doing this? And if you're not quite sure, always opt for the more safer side. And so that includes staying away from indoors. Please, 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 if you're in an indoor area where there's not a lot of air going through, try not to be there. Wearing a mask at least, and then washing your hands immediately. Just try not to be stuck in a stale air building for longer than a few minutes at a time. So if you want to eat at a restaurant, I usually try to opt for eating outside, where there's a lot of air and I get a lot of space from other people. Okay, and I know you can't eat with a mask, so that's why it's more important to be a little bit more cognizant of where you're at. Finally, please be kind. I try to answer a lot of COVID questions from people from different parts of the United States, even from different countries, and I do my best to try to keep them calm and to try to dispense common sense advice, not necessarily medical advice, in order to help them get through this. But sometimes I'm a human being too, and I also suffer from some PTSD, some anxiety, and being overwhelmed by this whole COVID thing. I'm trying to recover my own sense of self, but COVID is taking over, and people know me as one of the COVID guys that they can talk to. And I love and I'm honored, very, very honored to have that position. But again, I have limits, and I have to abide by those limits. But I do want you to be healthy, and I do want you to survive and enjoy life again. Just be kind. Be kind to each other. Be kind to me, and I'll try to be kind to you back. And if I'm a little bit irritable, then just understand that I'm only human. But I really do have your best interests in mind, truly. And of course, that's all free. I just ask you to just kind of not abuse that relationship. Thanks again, you guys, for following me. I will do my best to try to give you up-to-date information. Of course, there's a lot of resources that I prefer that you go to and do your own reading. Basic stuff, definitely. You can ask me questions. Try to keep it to one question at a time. All right, you guys please keep safe. Thank you so much for your kind words and your encouragement. That really helps me do my job. Truly it does. I may not reply to you, but just know that it really helps me get out of bed each